Myself, Keshav Murthy. I'm a first year senior resident, Surgeon Oncology, BHU Varanasi. I'm here to present a journal, clinical outcomes in early breast cancer with a I-21 gene recurrence score of 26 to 100 assigned to adjuvant chemotherapy plus endocrine therapy. A secondary analysis of the TAILORx trial. It's a it was published in as we all know, breast cancer is the most common cancer in women. Hormone therapy, adjuvant treatment, hormone receptor.
Keshav, we are losing you.
Sir,
Keshav, we are losing you in between.
My network is good. I don't know.
Okay, continue anyway.
Yeah. Yes, sir. Anti-estrogen therapy has reduced recurrence rates significantly. Overt cytotoxicity is a significant concern among the patients and physicians. It has been estimated that large percent of patients receiving chemotherapy for low-risk breast cancer may be overtreated. Recurrence score. What is this recurrence score? In this particular study, Oncotype DX, a 21 gene recurrence score assay, is was used, which is a commercially available gene expression assay that provide prognostic information in hormone receptor positive breast cancer. This particular gene panel, it includes 5 reference gene and 16 cancer related genes, including those associated with cell proliferation, invasion and hormone response, which is shown in this table. This test generates a recurrence score of score between 0 and 100 that correlates to the likelihood of disease recurrence within 10 years of diagnosis. There are various other multi-gene assays like MammaPrint test, which analyzes 70 genes to see how active they are and calculate a risk of low risk or high risk category. And there is an EndoPredict test which analyzes 12 genes, which similarly categorized into low risk and high risk. And there are other tests like Prosigna breast cancer prognostic gene signature assay, which analyzes 58 genes, and breast cancer index test, which analyzes activity of 7 genes to help predict in node negative hormone positive breast cancer, coming back to 5 to 10 years after diagnosis, to help if extending hormonal therapy 5 more years is it beneficial or not. Before going to this particular journal, I'd like to mention about a popular trial, B20 study of the National Surgical Adjuvant Breast and Bowel Project, popularly known as NSABP, which was published in Journal of Cancer Institute in 1997 by Bernard Fischer et al. It was conducted to determine whether chemotherapy plus tamoxifen would be of greater benefit than tamoxifen alone in the treatment of excuse me, sir. In the treatment of patient with axillary lymph node negative estrogen receptor positive breast cancer. There were total 2,306 patients were randomly assigned to one of the 3 treatment groups following surgery. First group received tamoxifen alone, and the second group which received methotrexate, 5-fluorouracil and tamoxifen MFT, and third group received cyclophosphamide, methotrexate, 5-fluorouracil and tamoxifen. Compared with tamoxifen alone, chemoendocrine therapy reduced the risk of ipsilateral breast tumor recurrence after lumpectomy and the risk of recurrence in the other local, regional, and distant sites. Risk of treatment failure was reduced after both types of chemotherapy, regardless of the tumor size, tumor estrogen or progesterone receptor level, or patient age. However, the reduction was greatest in patients aged 49 years or less. B20 trial, statistical analysis failed to identify a subgroup of patients with negative nodes and ER positive tumors who failed to benefit from either MFT group or CMFT group therapy, which led to arise. Should all patients with negative nodes and ER positive tumors be treated with tamoxifen plus chemotherapy? And is the benefit received adequate to justify such treatment? Later on, after this study, the very popular trial, TAILORx trial, which was published in New England Journal of Medicine in July 2018 by Sparano et al., which the main idea of this TAILORx trial was to see whether the intermediate group with the recurrence score of 11 to 25, whether they had any benefit of chemotherapy, to find out that endocrine therapy was non-inferior to the chemotherapy in this particular group. The protocol of this TAILORx, which is an abbreviation which stands for trial assigning individualized option for treatment in breast cancer. It had a different definition for risk categories than the standard one, where the for low risk was less than 10 and high risk was 26 and above. The intermediate was between 11 and 25. Patient with a low recurrence score, defined for the study as less than 10, are treated with anti-estrogen therapy alone. And a recurrence score of less than 10 was chosen as a threshold because it has been associated with a less than 5% rate of 10-year distant recurrence if patients are treated with tamoxifen alone. A patient with high recurrence score of more than 25 are treated with chemotherapy followed by anti-estrogen therapy. This threshold was chosen for high risk because it is associated with a 10-year distant recurrence rate of 20% on average, and because chemotherapy has been shown to be beneficial in this group. This was actually found out in the B20 trial, which I was mentioning earlier. And patient with the recurrence score, this is the main group where TAILORx trial was focused. In the intermediate range, 11 to 25, from the primary study group, are randomized to anti-estrogen therapy alone or chemotherapy plus anti-estrogen therapy. This study is powered to detect the non-inferiority of anti-estrogen therapy alone versus chemotherapy followed by anti-estrogen therapy. In this particular TAILORx trial, there were totally 4 arms, as mentioned here. The first arm A was the low risk group, where they were given only the anti-estrogen therapy, and arm D was the high risk group, where recurrence score of more than 25, where they were given both chemotherapy followed by anti-estrogen therapy. The arm B and C was the intermediate risk group, where they were into arm B was the group where they received only the anti-estrogen therapy, and arm C received both chemotherapy and endocrine therapy. And the journal which we are going to discuss is is analysis of this arm D group, where the data was taken from the arm D group to find the clinical outcome. This is the TAILORx trial pie chart showing in the color orange, 67% was the primary group, which is the intermediate group of recurrence score falling between 11 and 25, where they had both arm B and arm C, where hormone therapy was combined with chemotherapy in one arm, in arm C, and the other arm B was given only the hormonal therapy. And arm A, that is 16% of the patient of the total patients received hormone therapy alone. This arm D is a 17% where both chemotherapy and endocrine therapy was given with 26 to 100 recurrence score. In this study, prediction of chemotherapy benefit was initially established in the prospective retrospective validation study, including primary tumor sample from the 651 patient enrolled in the B20 trial with hormone receptor positive and axillary node negative breast cancer randomized to tamoxifen or chemotherapy plus tamoxifen. In the B20 trial, after taking into account the R2 status, R2 negative status, the final B20 trial had a sample size of 122 out of the 651 patients, where they could find out the benefit of chemotherapy in the high risk group. And this particular journal provides a descriptive analysis of clinical outcomes, characteristics, and adjuvant chemotherapy regimens for patients with a recurrence score of 26 to 100 assigned to receive chemotherapy, including regimens largely including taxane and or anthracyclines and plus endocrine therapy. As I said, the objective of this study is to describe the clinical outcomes for women with a high recurrence score who received adjuvant chemotherapy plus endocrine therapy in the TAILORx trial, a population expected to have a high distant recurrence rate with endocrine therapy alone. The methodology is this was a prospective clinical trial. All women had an oncotype DX recurrence score assay performed in a central laboratory. Clinicians were able to select one of the several commonly used chemotherapy regimen. They were given a choice to choose the chemotherapy regimen, and participant with a high recurrence score of 26 to 100 and we were assigned to the chemotherapy which I was mentioning, arm D, were enrolled in a voluntary prospective registry. As I mentioned, the data was taken from the TAILORx arm D, where a total of 1,389 patients of the 1,737 patients, that is around 80%, with high recurrence score was taken after the sufficient baseline follow-up information was available. This is a table showing the various chemotherapy regimen chosen to treat the patient. I'm going to show in the different chemotherapy regimen and in the result table. This is a standard study endpoints which is going to be discussed in the further slides, where the definition of invasive disease-free survival, IDFS, it is defined as a time from the registration of the to the first event, where the first event could be ipsilateral breast tumor recurrence, IBTR, or a local recurrence, regional recurrence, distant recurrence, contralateral second primary invasive cancer, second primary non-breast invasive cancer, or death without the evidence of recurrence. And other thing is the distant recurrence-free interval. It is defined as a time from the registration to date of distant recurrence of breast cancer or of death with a distant recurrence if death is the first manifestation of distant recurrence. Referred to here as a freedom recurrence of breast cancer at a distant site. Another definition is of relapse-free interval. It is defined as a date from the registration of the first recurrence of breast cancer, which can be ipsilateral breast, loco-regional or distant, or to the date of death with the recurrence if death is the first manifestation of recurrence. It can be referred as freedom from recurrence of breast cancer. And overall is defined as a date from registration to death from any cause. Statistical analysis of the clinical outcomes, which is the main part. Among the 1,389 patients with a recurrence score of 26 to 100 included in this analysis, this is a table showing at the end of 9 years of follow-up. The study took place between the registration happened between 2006 and 2010, and 5 years follow-up was seen at 2015 and 2018. The final data was collected at the end of 9 years of follow-up. This is a table. There were around 101 events of distant recurrence overall, and any invasive disease free survival event around total 189 patients had events of total in the 9 years follow-up in the cohort of this 26 to 100 people. This is a table showing various chemotherapy regimen at the end of 5 years of follow-up. Again, this showed a invasive disease-free survival event of around 134 at the end of 5 years, and a distant recurrence of a total of 80 patients had a distant-free distant recurrence at the end of 5 years among the 1,389 patients. The results in the result, patient and the tumor characterized by the adjuvant chemotherapy regimen. The total in the TAILORx trial, there was total of 10,253 eligible women were registered between 2006 April and October 2010. Among the 9,007 eligible participants with follow-up information, including the main analysis set, 1,389, that is 14%, had a recurrence score of 26 to 100, and of whom 42%, that is the 26 to 30, the first initial 26 to 30 recurrence score group had that particular recurrence score was seen in 42% of people, and 58% women had recurrence score of 31 to 100. This is a bar diagram showing a various chemotherapy regimen. As we can see, docetaxel and cyclophosphamide was the most common chemotherapy which was used in this particular adjuvant setting, and the first generation cyclophosphamide, methotrexate, and 5-FU regimen was the least preferred regimen. Clinical outcomes in the overall population and by the chemotherapy regimen. I will show the next in the next slide. The estimated 5-year rates of freedom from recurrence of breast cancer at a distant site were 93%, and freedom from recurrence of breast cancer at a distant site or a local regional site was 91%, and invasive disease-free survival was 87.6%. The overall survival was 95.9% in the chemotherapy group. This is a Kaplan-Meier estimates of the clinical outcomes at the end of 5 years of patient with the arm D group. We can see here the overall invasive disease-free survival was 87.6%, and overall survival was 95.9%, signifying the use of the chemotherapy in that particular group. And this particular group, anthracycline and taxane group, it had better results compared to the other group of chemotherapy, where they had an overall survival of 97.2%. This is another table showing the outcome at the end of 9 years for the same group, where again invasive disease-free survival at the end of 9 years was 75.7%, and overall survival was 89.3% among all the patients, irrespective of the chemotherapy. And taxane group had a overall survival of 90.9% compared to the other group. Estimation of the to show the clear benefit of the chemotherapy in this particular group. This particular study to find out what if this particular group had a endocrine therapy alone. The expected rate of distant recurrence through 5 and 9 years of patient with recurrence score of 26 to 100, that is the arm D of the TAILORx, if treated with endocrine therapy alone, was estimated by combining the patient from the TAILORx arm D with patient-specific chemotherapy benefit information from the R2 negative cohort derived from the NSABP B20 trial. They use the data from these two trials to find out what would be the 5 and 9 year recurrence rate, and the overall came out to be the expected rates of freedom from distant recurrence without adjuvant chemotherapy in this cohort was 78.8% at the end of 5 years, and 65.4% at the end of 9 years, which is very low as compared to the therapy and endocrine therapy group. And they are also stratified with the recurrence of this 26 to 30 group, the expected rate was 5 and 9 years were 89.6 and 80.6, and for those with a recurrence score of 31 to 100 was 70.7 and 54% respectively for 5 and 9 years. One we can learn from this is that chemotherapy had a definitive role in that high-risk group, and this stratification also will also give some idea that this initial 26 to 30 with the endocrine therapy alone, they had a rate of distant recurrence rate 89.6 and 80.6 at the end of 5 and 9 years. 31 to 100 was 70 and 54, which definitely show that this recurrence score, it can validate saying that this recurrence score definitely can prognosticate the recurrence and overall survival, and also the benefit of the chemotherapy, which is the main purpose of this study. This is a simple table showing the data which I had mentioned. The chemoendocrine therapy, the distant recurrence rate of at the end of 5 years was 93%. The expected outcomes if treated with endocrine therapy, you can see the difference of 15% here. And freedom from recurrence of breast cancer at a distant site of 9 years was 86.8 and 60.4 in the endocrine therapy alone. Few point to discuss in the secondary analysis of a prospective clinical trial, including 1,389 women with hormone receptor positive node negative, ERBB2 negative, which is nothing but R2 negative, axillary node negative breast cancer. A I21 gene recurrence score of 26 to 100 assigned to a receive adjuvant chemotherapy. The estimated 5-year and 9-year rate of freedom from recurrence were 93% and 86.8%. And these particular findings were highly consistent with the comparable population with R2 negative disease in the B20 trial. The B20 trial had its results with a methotrexate and 2 group, as I had mentioned. Methotrexate and 5-FU with or without cyclophosphamide at 88%. So they had a similar rates of, and substantially this result was better than the similar patient treated with tamoxifen alone in the prospective validation studies of 21 gene assay. As I told that comparing to the endocrine therapy alone, in this high risk group, chemotherapy had a definitive benefit in the distant recurrence free survival and the overall survival. And outcomes were also similar in the patient enrolled in the TAILORx trial with a recurrence score of 0 to 10 and 11 to 25 treated with endocrine therapy alone. Compared with the B20 cohort, supporting the use of outcomes from the B20 trial in planning the TAILORx trial. The strengths of this study was prospective nature of the trial and treatment assignment. The large sample size of the high recurrence score cohort chemotherapy related to the prior B20 validation study. As I told, a very good large sample of the high risk group compared to the earlier B20 study group, where after taking into account the R2 negative group, it had a sample of 122. The high compliance rate to assign the chemotherapy, it was around 94%, and the use of systemic adjuvant therapies reflecting the current clinical practice, including rather than the tamoxifen in postmenopausal women, and the use of second and third generation chemotherapy regimens, including anthracycline and taxanes in the most patients. The limitations of this study was that the lack of randomization to endocrine therapy alone, interaction between the chemotherapy benefit and high recurrence group, and the limited follow-up and consequent potential for bias in reports beyond 5 years. To conclude, the high recurrence score of 26 to 100 is prognostic not only for the high distant recurrence rate of approximately 30% with endocrine therapy alone, but also greater effectiveness of chemotherapy in reducing the risk of distant recurrence. This was the main purpose of this secondary analysis, to prove that high risk group as per the definition group said that they are definitely going to have a recurrence risk. But again, to prove that chemotherapy had an active role in this group, that was the main purpose of this study. And the findings from this analysis add to the evidence base supporting that use of 21 gene recurrence score assay to guide the use of adjuvant chemotherapy in patients with hormone receptor positive and HER2 negative axillary node negative breast cancer. Thank you. Thank you, sir. Hello.
Thank you, Keshav. Very well presented and very comprehensive. So the topic is open for discussion. Keshav, you can stop your slide share so that we can see each other.
Sir. Yes, sir.
Yes. Any questions, comments?
I would. Sir, I would. Sorry, I would like to ask this presenter that in which early breast cancer, hormone positive, HER2 negative, node negative, early breast cancer patients, he would like to apply the result of the TAILORx trial or this trial. In which subgroup of this population would you like to apply this?
The TAILORx trial was actually was focused on the intermediate group, the 11 to 25 recurrence score group. But the study which I presented was to find out about the high recurrence group, the effect of the outcome with the chemotherapy and endocrine therapy, ma'am. Yes, ma'am.
So in this D,
yes, ma'am.
When I went through the data, the mean tumor size was 1.5 centimeter.
Yes, ma'am. Yes, ma'am.
And 67% of the tumors were less than 2 centimeter.
Yes, ma'am. That
median age was 56 years and 70% of the women were postmenopausal.
Yes, ma'am.
Around 70 and 95% received post-operative radiation therapy.
Yes, ma'am. Yes, ma'am.
So, and only 7% were grade 1 tumors. So, we have to keep these things in mind probably before applying these criteria to our patients. Because patients in TAILORx trial, especially in arm D, small tumors and postmenopausal women.
Okay. Actually, I
Anshika,
not go with the full detail.
Yeah, I'll tell you. Anshika, what has happened in TAILORx trial is that it is a trial designed for early breast cancer, node negative and ER positive tumors. So you expect a smaller tumor size here. And the trial was designed to actually see whether among this group, can we have a subgroup which will benefit from the endocrine therapy. That was the main purpose of designing the TAILORx trial, which was published in the 2018 NEJM.
Can I ask a question, Manoj, please?
Yeah, sure, Sumohan.
What price of oncotype is being used to request it?
Sumohan, we didn't get you. I think your speed is.
What is the price of Oncotype DX in India? And the second question is, what is the criteria being used to request it?
Keshav, you want to reply or should I?
Sir, I'm not aware of the cost.
The cost of Oncotype DX in India is about 90,000 rupees. And the Oncotype DX is not yet approved by FDA. And so there are no approved indication of its use.
Okay.
The only gene signature, which is approved by FDA is MAMA print. Other than that,
and what is the average price of
MAMA print approximately
what
same.
is the average
MAMA print is about 1.25 lakhs.
But if somebody has chemotherapy, how much does the whole thing cost in terms of the medicine and the hospital cost?
The chemotherapy cost is very low in India because we have a ordinance called DPCO, which is Drug Price Controlling Act, DPCA, and under the DPCA, the price of paclitaxel as well as the carboplatin, which is commonly used, cyclophosphamide, is very much controlled. Like price of 5-FU is 20 rupees for 500 milligram. The adriamycin you will get it for 250 rupees for 50 milligram. And paclitaxel you will get for about 1200 rupees for 260 milligram. So the price of chemotherapy is not a concern here. The concern is the price of determining whether the patient should get chemotherapy or should not get chemotherapy.
Yeah, so the reason I'm asking the question is when this was approved in UK, the NICE looked at the evidence, and the two things they looked at is clinical effectiveness and the cost effectiveness.
We have another reason that precludes too much use of Oncotype DX in India, because we deal with about 35 to 40% of our patients are triple negative. So we don't have ER positive patients in India that much. So that is another reason why it is not much in use. And we don't get early breast cancers, node negative, 2 centimeter tumors. So most of our tumors are larger, T2 and above. We don't have a screening policy. We don't have mammographic screening. So by the time we detect them, we normally detect palpable tumors. So they will be bigger and none of them actually will fit in the Oncotype DX criteria.
That was exactly my point, that the tumor in this study, the patient group is so different from what we see. So that was exactly my point, that these patients are much older and these small tumors.
Can I ask the residents, what do you think about using this in premenopausal women, the 40 to 50 group?
Keshav, for you.
Yes, sir. Sir, in premenopausal women, we can use because if they come into this category of node negative and early breast cancer, the endocrine therapy is beneficial as it's been shown in the data. But in premenopausal, they can have that estrogen receptor. The chemotherapy less than 50 years what was seen in this trial, where they found out in the intermediate group, they actually found out that chemotherapy had a role. That was not actually completely, it was only suggestion that was told that chemotherapy suppressing the ovarian function. So that young age group had a role of in the intermediate group, sir.
Keshav, let me reframe Sumohan's question. You had a young woman, 30 years old.
Okay, sir.
She has an early breast cancer, 1 centimeter. She is node negative and hormone receptor positive. Would you consider doing a Oncotype DX? That is first. And if you do and you find that she is low score, would you put her on endocrine therapy alone? You got the question?
Type DX, she can, if she undergoes and if she comes into the low risk group, endocrine therapy alone can give a good result of it was as shown in the study, 3% of recurrence was seen at the end of 10 years. So definitely a advantage, I would say, sir.
And what will happen after 10 years? Because I expect her to live 25 years at least, or maybe 30. She's only 30.
Yes, sir. This I'm not sure, sir, but
So you should say that 10 years follow-up is not sufficient to...
Yes, sir. She needs a further follow-up and monitoring.
Let's wait for longer follow-up. Let's see what happens after 20 years or 30 years, and whether these groups still keep separating, or the endocrine therapy group starts performing bad. Because what's going to happen is that after 10 years, the endocrine therapy perhaps is going to be stopped. In a premenopausal woman who is getting a tamoxifen, maximum tamoxifen that you are going to give is for 10 years. So after 10 years,
Yes,
you are
sir.
going to withdraw tamoxifen. So what will happen after you withdraw tamoxifen? That is something which you still have to see. So endocrine therapy alone may be a good option or may not be a good option, but for whom it is a good option, we don't know. Anything else do we have? Hello. Yeah, Tarun.
Sir, is Durgesh here?
Yeah, Durgesh.
Sir, in young patient, should we consider for the ovarian suppression separately to start with the aromatase inhibitors?
This is another different line of treatment that you're talking about. But you have to understand that if you are going to suppress the endogenous estrogen production in a young woman, you have to bear the consequences of it. Because so far to my knowledge, there is no study that has shown that aromatase inhibitors after ovarian suppression in young women with breast cancer is better than tamoxifen.
Can I share the Christie protocol for this?
Yeah, sure.
Premenopausal women who are high risk are given the option of ovarian ablation using Zoladex and put on the letrozole, or they can have oophorectomy if they have finished the family. So the high risk women in the premenopausal group are given the option of it.
But I think it is only used for metastatic setting, but not as an adjuvant.
No, even in adjuvant setting, we are using it.
Okay, Christy is using in adjuvant setting. Okay.
I've got
high risk group.
Yeah.
To Sumosar and you. That is, are we going to treat this cohort? What you were talking about is young early breast cancer with a young age, because nowhere it is written very specifically that young age is a kind of aggressive. Should we treat this kind of cohort of patients very aggressively so that they can get a better benefit?
Arnab, that's a good question, but the reason that I am saying is that when I treat a young patient, say 30, 35, 40, I am not looking at a 10-year survival here. I'm looking at a 30-year, 40-year survival here. And unfortunately, none of my studies have that longer a follow-up, except if I say early breast cancer clinical trialist group, tamoxifen trial, which was published in 1984-85, and where we have something like 20-30 year follow-up available now. But for most other studies, we don't have more than 10-year follow-ups. And this is something which worries me when I treat a younger patient, because in a younger patient, I'm looking for something, okay, fine, 90, 95% or 93% 10-year survival is good. Agreed. But what you are looking for in a 30-year is a 100% 10-year survival and probably 90% 30-year survival.
Yes.
That is something that I should be looking at.
Totally agree. Younger patients need much more intense treatment.
Exactly.
Yes, Arnab.
Younger patient, there is no point mulling over whether we are oncotype DX. It is better to are on the excess or treating it excess than going for a oncotype DX, just going for a recurrence code in Indian scenario, where the price has to be borne by the patient.
Yes, Arnab. The Indian scenario is any tumor more than 1 centimeter, you do chemotherapy, and if they are receptor positive, put them on hormone therapy.
Exactly.
That is the dictum here. I think everybody follows the same golden rule.
I think what you have to understand is in places like UK where there is a screening population, we have to be careful not to over-treat patients. So there is this whole concept of safe de-escalation of treatment, and Oncotype DX is part of the safe de-escalation treatment.
That's also true. A perspective we have to think in mind.
That's true. But right now we don't know what is the optimal treatment. De-escalation, actually, there had been a lot of debate over treatment versus optimal treatment versus under treatment. And to me, over treatment sometimes is better than optimal treatment, which may at the end of the day turn out to be under treatment.
And probably in one or two papers he has told about that once we see the recurrence is actually coming up in younger patients after 25 years. So in a younger patient, that cohort we must that told is a 30 years. We should have a of 30 years, not 10 years.
Yeah, Arnab,
and interestingly,
yes, Mohan, carry on.
Interestingly, the cohort of patients who have late recurrence after 25 years are the node negative ER positive cancers.
Yes, sir.
Yes.
Which we originally thought was good prognosis. So strangely, if you have a bad cancer and you survive 10 years, you actually do better in 20 years.
What I was suggesting was that when we are talking of younger women with breast cancer, I think one thing that we should all do is look for BRCA that we are not doing right now. It's my suggestion that people who are BRCA positive should be treated differently than BRCA negative. What is your take?
This should be included in the protocol, sir. They should be included in protocol, and they should be treated. They should be treated aggressively. They should be counseled for other things. This is not done across the board in India.
Yeah, this is not being done.
And surprisingly enough, we have seen in our clientele, we are finding quite a lot of patients who are BRCA positive.
Yes. Yes. Do we have any other question or suggestion or discussion point to discuss?
Sir,
can I share one thing before I forget?
Yeah.
Why I asked that premenopausal question is even after TAILORx, anybody who's premenopausal and the score is between 21 to 25, the oncologist have a look at the whole tumor profile and then have a chat with the patients about decision about chemotherapy or no chemotherapy. So 11 to 26 is a big group. So nowadays the premenopausal between 21 to 25, the oncologists look at the tumor profile and think about it again. Look at other 67 to make the final decision.
That's true. That's true.
So one more question. In this study, this group D score 26 to 100 had only 7% of their tumor grade 1. Whereas 0 to 25 score, the grade 1 was 34%. So I was just wondering, if you have a patient fitting into the criteria but has grade 1 tumor, so what do you do with that? Do you still go ahead with the score, or do you not do the score and forget about the chemotherapy here?
I think at present the
Sorry,
dictum is to go for the score. There are more kind of scores coming up. Like one score has come up from India itself, which is called Can Assist. I don't know how many of you
Yes,
have
yes.
heard of it.
Yes.
Now this Can Assist is something which is using 5 molecular markers with 3 clinical parameters. So now people are increasingly talking about including the genes with the clinical parameters and including clinical parameters in the decision making. And there had been a symphony study where they have used 4 different gene signatures. They use the gene signature Oncotype DX, they use MAMA print, then they use, there is one signature that differentiates various luminal types from each other, and then thyroprint. Thyroprint is one which predicts the treatment benefits, which is still a research tool. So in Symphony trial, they used 4 gene signatures to actually come to a conclusion. So people are working both ways. They are using multiple genes. They are also using genes with clinical criteria. And I think there is a lot that need to come. But most of the work is being done with the estrogen receptor positive early breast cancer. And to me, this is not the group I should be worried about. I should be worried about triple negative breast cancers.
Yes.
And I'm surprised that nobody is working on it.
Triple negative breast cancer, actually, I was just reading today. So I was just being from surgeon's perspective, I was thinking even in early breast cancer, triple negative, ideally we should do IHC and find if it is triple negative, give them neoadjuvant and find out if there is PCR. If there is no PCR, then we do PD1, PDL1 score. And if it is high, then we should consider immunotherapy with PD1, PDL1 inhibitors in the adjuvant setting with the whatever adjuvant systemic therapy we are going to give. So even triple negative or genus disease, and rather than operating them first, we should give them neoadjuvant and then probably go ahead with the surgery and look at the PCR rates.
But Anshika, I have got a different take. In early breast cancer, triple negative, yeah, okay. I am agreed to the fact that you should be on a neoadjuvant as early as possible. That is understood. But again, if the clinical kind of improvement or the clinically it is a total response with the chemotherapy, then find it out later on the PCR what kind of surgery you will do. Then your BCS is completely out.
I agree, sir. I agree. Totally, I agree.
Because
it's a
in
challenge
a
for the
setup,
surgeon. Yeah.
We don't have a marker put or in a government setup or in a
even in my setup,
like
we are not able to put the markers. So we go ahead, if it's a BCS, it's early breast cancer, we would prefer to go ahead with the surgery first.
Then you have to go for and convince the patient that we'll do a mastectomy with again
Agreed,
primary
sir.
reconstruction.
Agreed.
I think Arnab, I will be sharing. I should share with you that how I do it and how do we place a marker for our tumors. It's a very cheap and very easy technique that we are using. All it requires is an ultrasound, and we use K wires, which are cut into small pieces, and we use the older true cut needles, where you can take out this stillet to push in the marker in place. It's a fantastic technique. And if I get a chance, I'll ask some of my residents to actually present it, because it is something which is very easy to do. It is something which is very easy to do. So what we do is we place 6 markers. And these markers are placed using an ultrasound and a hollow needle. And simple KY.
Are you taking out? Are you taking the whole imprint of the tumor pre-chemotherapy?
Yes.
Because that's where the debate is. Okay, we're not at the moment. We don't take the whole footprint. We don't take the full footprint.
Yeah, we do.
So the neoadjuvant chemotherapy is a very interesting topic. I don't think we have the full answer to it. The two things I would say we use it for is triple negative. We get time for doing the BRCA testing, so we can delay the surgery till we know that whether they're BRCA positive, and then we can do kind of bilateral surgery. And it's almost like a live experiment. You almost see whether the tumor is responsive or not. And I think the challenging part now is that if you have a complete PCR, you know you're dealing with a better prognosis tumor.
Definitely.
It's when you have residual disease, that's where the challenge is. And at the moment, there has been a bit of a funding issue, but if you look at the data, the people who are not getting complete PCR are the ones who will benefit for continued treatment with something like a capecitabine. And I think that is where, if they are HER2 positive, they continue with Herceptin. So that's not a problem. But if it's a HER2 negative, triple negative tumor, then I think if you look at the data, there is increasingly capecitabine improving survival and disease-free survival in patients with incomplete pathological response.
So Mohan, do you have any experience with the androgen receptors blockers?
Not much. It's not being used much. But what we are using in BRCA gene positive patients are PERP inhibitors.
Yeah.
So that is one of the reasons for sending them for BRCA gene and sending for chemotherapy is that if they are BRCA gene positive, they can add PERP inhibitors. We haven't used androgen receptors yet. I think the data of that is still a bit premature. But that's another very interesting thing to look at. Very interesting thing to look at.
So, sir, you are using PARP inhibitors in triple negative, metastatic, as well as advanced, as well as breast cancer, or do you have a?
Yes. So the PARP inhibitors are being used sparingly. They are being used for BRCA gene
in BRCA
and also BRCA positive patients, and also the patients who are, say, we do 3 MRI scans. So one to start, one in the middle, one in the end. So in the middle, if there is a triple negative cancer who is BRCA gene positive and is not responding to the first half of the treatment, they are the ones the PERP inhibitors are considered. But there is good data to say the BRCA gene positive actually is a good thing to add.
In all the early breast as well as advanced, We only
talk about early breast cancer. Metastatic is different, but early breast cancer we're talking about.
Okay.
Do we have any other question from residents? Any other point, any other thing that you want discussed? Bhavin, you have something to ask?
Sir, hello?
Yeah, Bhavin.
Sir, I wanted to ask something my institution is following, that patients are not affording Oncotype DX. So whether we can use a 67 as a prognostic marker to make decision regarding chemotherapy in early breast cancer?
I think all of us are not using Oncotype DX, and all our therapy decisions are based on ER, PR, HER2, Ki67, grade of the tumor, lymphovascular invasion, and then TNM classification.
Is anybody using a free online tool called Predict? If you type in predict.nhs.uk, what it will do is if you put in your patient's details, age, and all the clinical criteria, it will give you the benefit of chemotherapy over 5 years. So
Yes.
I would request residents to just try it out. I think it's also a very good self-learning tool of benefits that when you're explaining to the patient. I think it's a very valuable tool you can use. So just predict.nhs.uk. It's a free software, online software.
And also what Dr. Pandey has told, the CAN assist is also good. They are IHC based, so they are cheaper than Oncotype DX.
Yeah, but actually the problem with CAN assist is that CAN assist doesn't take ER, PR, HER2 into account, and that is the biggest drawback of CAN assist.
Yes.
So all luminal types or even basal cell types have been clubbed into one category, which we know is not possible. And I had a discussion with their team leaders, and I have told them that this is one of the disadvantages, because until unless you take luminal types into account, because that's where the prognosis separation started. The receptor positive, hormone receptor positive, better prognosis, triple negative, worse prognosis, HER2 enriched, middle prognosis, and that way. And if you are not taking the hormone receptors or the HER2 receptors or proliferation index into account, and you depend upon 5 genes which are related to, not related to either the luminal expression or they are related to proliferation. And you can say that irrespective of the receptor status, the proliferation rates are the same in all the tumors, then I think it is very difficult to digest for me.
Yes.
They may be right, but the evidence points that luminal types are one of the important prognostic indicators.
And I want to know from Sumonda that what is EndoPredict in your UK?
EndoPredict is not used that much. Actually, to be fair, before the TAILORx came out, EndoPredict was a bit better than an area of where we didn't know what to do. So we were using EndoPredict more that time because it gave a more clear-cut answer. There wasn't a gray area like Oncotype. But after TAILORx, I think we do use it, but it's not used that much. It's mostly on the NHS we use Oncotype DX. Hardly anyone uses EndoPredict. And because we've got used to our Oncotype DX, we keep using it. EndoPredict is used more in the private sector because it is slightly cheaper, because it's about 2,500 DX in the UK. So it's slightly cheaper on EndoPredict. So the private insurers, they prefer EndoPredict over Oncotype, but that's what it is.
Manoj sir, I want to ask you if Oncotype DX has been, are there any studies to validate on Indian patients?
Anshika, I'm not aware of any Oncotype DX data from Indian patients. To the best of my knowledge, it is being used, but I don't think that the Indian data has been separated out from other subgroups.
It's very difficult, I think, to do it in Indian population, a big, large study, because it will cost a lot of money. And anybody will fund that amount of money in a patient in Indian scenario.
But Anshika, I'll give you an idea. A very good idea. You know the 21 genes that Oncotype DX uses, right? And there is a publication from Safdarjung Hospital, I think last year, which I'll send you, that has looked at the differential gene expression between Indian and Caucasian women. And what I'll suggest is that you look at that 6,000 odd gene which are differentially expressed and see if these 21 genes are there or not. If they are not different, if they are not there, then you can assume that Oncotype DX will also work in India. And if you find these 21 or say 5 genes into differentially expressed genes, then it is not going to work for Indian women. It's a little tedious task, but it can be done. It can be done. I'm giving you an idea. You can write actually a paper on it. I'll send you the gene chip data from Safdarjung in Delhi. What they have done is they have done the microarray, whole genome microarray on Indian patients. And they have compared it with the Caucasian population using the databases available on TGCA. And they have come up with 6,400 genes which are differentially expressed between Indians and Caucasians. So now you know that what are the difference in expression. And if you know the difference in expression, all you have to do is just go back to Oncotype DX, see if 21 genes are there or not there, and you know that it is going to work or it's not going to work. You can hypothesize.
Interesting.
It's a good idea, na Suman?
It is good ideas. Yeah. I mean, the thing is, the Indian population, there are lots of constraints because of the cost and everything. So if you're going to spend 9,000 rupees and the cost of chemotherapy is not that much, you might as well err on the side of caution and give them chemotherapy.
True. Chemotherapy is cheaper than the Oncotype DX.
Yes, sir. In India, it is a
Here, chemotherapy cost is much more, and that's why it's cost effective. So the chemotherapy, if you're not using Herceptin, I think it comes to about 25,000 or something like that, which 25,000-30,000, which includes obviously the hospital cost. So 2,500 if you do 10 and you miss out on chemotherapy or even on 4, then you get your money back for the health system.
Actually, since the time the biosimilars have come, the trastuzumab in India right now costs 16,000 rupees only. So 16,000 is something like $20, $20 US.
Yeah.
Yes.
That is the cost of trastuzumab in India.
Imagine where we were about 12, 13 years ago to where we are now.
Yeah.
The cost has plummeted.
And now we have at least 10 biosimilars, 10 companies manufacturing trastuzumab, where the market is not that big because about 20% are HER2 positive. So it's not a big market, and that has seen the cutting down of prices in such a way that it's a boon to the patient.
Yeah, I mean, the pharmaceutical industry in India is absolutely amazing. What they've done in terms of cost of the medication.
Mario, are you still with us?
I agree. The cost of Oncotype is high for us, Latin America. So we have to look at the clinical pathologic features. But in some cases, on the private basis, we can offer to our patient Oncotype.
It's good to see, Mario. And how is the COVID situation in Brazil?
In Bolivia. I am from Bolivia.
Yeah, Bolivia.
Yeah. Yes. In Bolivia, we don't have a screening program. So the very very low tumor is very difficult to find.
Okay.
That we should ask Sumanda that how Salford Loyal is managing this disaster and what is there in UK.
Sorry, what's the question? I missed it.
And I will stop completely on the cancer surgery.
So it's a different situation for two reasons. One is there is some data saying that cancer surgery actually is quite risky at this time. And secondly, adjuvant treatment is being severely curtailed, where radiotherapy and chemotherapy is not being given to a lot of patients. So we are continuing with cancer surgery. We're not doing any breast reconstruction. We're doing simple surgery. A lot of patients who are suitable for wide local, who will not get radiotherapy, is opting to have mastectomies. We are not operating in the main hospital now. All the private hospitals have been taken over by the NHS, so we are operating in the private hospital to create, because the main hospital theatres are now being taken up as small ITUs with ventilators. So it's extremely very bad situation. Patients are really struggling to cope with not only the diagnosis of cancer, but also how we are treating them. We are suboptimally treating them. And we are at the moment collecting data on the patients that we are not giving full treatment. And if only in 3 weeks' time we will know whether we have harmed the patient or not. We might know which ones are safe to de-escalate. So anybody above 70 ERPR positive cancers, we are just clipping them and giving them letrozole. So we're only operating on the high-risk cancer, triple negatives, node positives, those kind of patients.
And what about the air handling unit of a hospital? Like in a ward or in OT, there are air handling unit. They are all centralized ACs. So when we keep a COVID patient in those wards, then what about the things will happen after 5?
Okay, so the situation is this, that if from last week, before last week, we were not screening patients for COVID. So from this week, what we have been doing is either swabbing them, or if it is less than 72 hours, then we are doing a one-off non-contrast CT of the chest. So to see if it infiltrate. So non-contrast CT of the chest is very good in screening. It's probably better than the swab, because swab, 25% of swabs can come back as false negative.
Agree.
Right.
So anybody we are operating, we are trying to do a non-contrast CT the day before to make sure that they don't have COVID. Because operating on one COVID positive patient affect up to 10 medical healthcare workers. And so the other things that we're doing, and we are routinely now using FFP3 masks when operating on any cancer patient. And there is a 20-minute downtime between theaters after the patient has been extubated, so that things settle down in theater, the aerosols settle down. Again, that's based on very little evidence, but that seems to be the best evidence we have at the moment. So it's extremely difficult situation. So it's taking us longer to do a theater list. We're doing no reconstructions, because the risk of implant infection, and then it takes longer to do that operation. If they have problems, then there is not much support, because MSC backup is not there. So we've gone back to basics for the time being, and I really don't know how long it will continue for. Or the other thing we're doing is neoadjuvant chemotherapy. We are stopping after 4 cycles rather than 6 cycles. And again, if anybody's having neoadjuvant chemotherapy and they have one episode of or neutropenia, it's immediately being stopped and sent back for early surgery. So it's a very difficult situation, very, very difficult situation. But thankfully, we have stopped breast screening now. The breast screening was going on, which was bizarre.
So do we have any other question, or we close
But
today's
cancer
session?
surgery is not without its risks in this time.
Yes.
So, sir, you are doing cancer surgery based only on CT findings and not going for a proper thorough testing, swab testing. What?
So non-contrast CT the day before.
Like the patient is asymptomatic. Asymptomatic.
Yeah. Even if they're asymptomatic, because asymptomatic patients can be virus shedders.
So what are you looking for?
We've had 3 cases in our hospital where patients had surgery, not breast surgery. Patients had colorectal surgery, and on the 3rd day have started showing signs for COVID.
Sir, what are the specific signs that they are only COVID and not any other corona or any other viral infection? Like, is there any specific signs in CT?
No.
Well, it's I don't have the exact report, but there is a CT criteria now. If you Google it, you'll find it. It's a soft infiltrate they're looking for, basically.
Yeah, but that is there in all SARS cases. It's not specific.
Yeah.
It's not all SARS cases.
It's not specific.
So at the moment, anybody with temperature and infiltrate, we are assuming it's COVID.
Yes, not proved.
Okay.
It's not proved otherwise.
Yeah, until proved otherwise. Yeah.
So like a simple adenovirus upper respiratory infection.
It can be, but very difficult to differentiate. Very difficult to differentiate. If they are being treated as if they're COVID.
Right. This thing is going to continue for a couple of years, you think?
I have no idea. There's a lot of talk about antibody testing. Again, that is not ready. And again, even if you're antibody positive, we're not even sure whether that gives you immunity or not. All data is again very problematic. So we don't know. We don't know how to get out of this situation. I have no idea. And I think we'll have to wait for the vaccine to come to be sure. But the vaccine is at least 12 months, 18 months away.
18 months.
It's a very difficult situation. Very difficult situation.
Okay.
It's we just don't know enough.
How also
all clinical trials are suspended.
Okay, then if we have nothing else to discuss, we'll end this session here. Tomorrow's session is recent advances in esophageal surgery. And I'll request Tarun to coordinate with Mandar. Mandar will be presenting. And we'll be starting at 6:30. Today there was some
All the best.
and that it got
safe.
You too.
You say,
Come on.
sir.
Okay. Bye everyone. Bye-bye.
Bye.